Bloomberg Audio Studios. Podcasts, radio, news.
This is Bloomberg Businessweek with Massar and Tim Stenovec on Bloomberg Radio.
Well, our next guest is a doctor, but modern medicine nearly killed him. He tells this story in the opening pages of his new book, Telltale Hearts, a public health doctor, his patients, and the power of story, which is out now. And to say it's gripping is an understatement. Neither Carol nor I could put it down as soon as we started reading it.
Yeah, to be fair, we've been talking about it in the newsroom. We're joined by Dr. Dean David Schillinger. He's director of the University of California, San Francisco Communications Research Program. Once again, his new book is Telltale Hearts, a public health doctor, his patients, and the power of story. He does join us from San Francisco. Dr. Schillinger, it's so nice to have you here on Bloomberg Businessweek. Take us back to 2010 and the episode that nearly killed you, because I do feel like you make a point of putting it at the beginning of the book. It's an important story. Take us back there.
Yeah, the reason that, first of all, thank you for having me on your show. The reason I put my story up front was not because the book is about a doctor who got sick and saw the light on what it's like to be a patient, but rather to make the point that a lot of the illness and burden of disease that we see in the United States that drives the healthcare costs that are so burdensome is a result of unhealthy exposures in our country. And in my case, I was unfortunate enough to have two nearly simultaneously exposures that got me quite sick. One was I was clearing a fire road with my sons, not knowing that the branches and trees that we were clearing were pure poison oak. And that led to a case of severe red man syndrome where my entire body reacted in a severe allergic fashion. And that exposure led me to be exposed to another unhealthy exposure, which is prednisone, which is a high-dose steroid meant to reduce my immune system's response, but and it did that quite well, and I was able to get through the red man syndrome. But a while later, one of the known side effects from high-dose steroids, these are like chemotherapy level steroids, is that I sustained an episode of major depression that got me really unable to work, unable to function, and with so severe that I had thoughts of suicide. And while I was very well positioned to get outstanding care because I am a physician, I have good health insurance, and I could navigate the system, for most of my patients, and I work at a public hospital, the series of exposures that are unhealthy that they have been subject to over the course of their lifetime are much more profound and numerous than mine, and their difficulty in accessing high-quality health care is much more challenging than I had to face. And so the rest of the book is dedicated to the stories that I've elicited from my patients over the course of being a primary care doctor for over 30 years as a public hospital primary care physician, and trying to demonstrate how important exposures rather than personal choices are to explaining the high burden of disease in our country.
But I also feel like it was an important conversation that you had with forgive me, I'm not going to get his title correctly, but a therapist, right? That ultimately, in having a conversation
Dr.
with
Duncan,
him,
yeah.
that it came out, which I think speaks to a bigger, broader topic. I think a lot of us talk about our doctors don't have time to actually have conversations with us and understand our environment, our full picture. And it sounds like he got the full
That's
picture
right.
and helped you figure out exactly what was wrong and get you to a much better place.
Yeah, what he essentially did is he elicited my story, and that's why in the title of my book, "The Power of Story" is, the last part of the title. It was his ability to sort of push the chart aside, the medical chart, the biomedical chart, and ask me in my own words what I thought could be causing my problem. And I had my own theory related to the steroids that had not been fully fleshed out with my other physicians. And it was his curiosity, his experience in having worked as a psychiatrist in a cancer center where a lot of people are exposed to high-dose steroids, that led my story to be uncovered. And really the thrust of my book is how important the elicitation of patient stories can be in terms of understanding their lifetime exposures, their social and environmental conditions, all of which determine their health and health trajectory and whether or not they will recover from their illness.
Narrative medicine, I think, right, is what they call it.
But it's not a system.
Yeah, there is a form of this that's called narrative medicine. Exactly right.
Doctor, yeah, go ahead.
Yeah. Well, what I was going to say is that we are so, I don't want to create the false impression that medicine should all be about storytelling. That would bring us back to the Middle Ages. Really what I'm trying to demonstrate is the importance of the alchemy between story and science, that when we combine the best of science with the best of listening to patient stories, we can get to the answer much more efficiently, much more cost effectively. And then when we aggregate these stories together in what I call narrative epidemiology, we begin to see the larger patterns that are causing disease in populations, not just individual patients. And so bringing together story and science is really what the thrust of this book is about.
That approach, though, I'm afraid, at least in my own anecdotal experience, is the exception and not the rule. For example, next week I have a dermatology appointment that I've waited months to be able to schedule, and I was able to schedule it within 15-minute increments. So I know that the maximum amount of time I'll have with this doctor for a full body check is 15 minutes. And I certainly have a list of things to talk to him about, but it makes me think that, the system that we have when it comes to medicine in this country, it's not one that's conducive to this idea that you espouse in the book.
I couldn't agree with you more. I mean, this book has a number of points that I make that are quite subversive in terms of being critical of the current system. That said, I think one of the problems in the current system that is most severe is the lack of access to primary care physicians. Now, I'm a primary care physician. I too have 15 minutes with a patient, and I just don't have to deal with their skin. I have to deal with their entire body. But I also can do it over the course of many, many years and get to know the patient intimately well and be able to elicit story over time. But I think until and unless we get to the point where we prioritize communication and conversation as much as we prioritize, and here I'm talking about financially prioritize, the ordering of MRIs and highly costly medications and tests that we do in lieu of the conversation. So, I instead of asking the patient about the realm of symptoms that they might have about the knee pain, I just order the MRI, boom, and I move forward to the next patient. That is not cost effective. We are wasting dollars when we do that as a nation.
Well, and it's kind of interesting because we all have stories about how our healthcare system is broken and the problems. And it sounds like the fix, what we really need to do, what would you say? We've got about 40 seconds and then we'll come back and talk some more. What we really need to do to improve health, fill in the blank, would be what?
Well, what we really need to do to improve health is to improve the social and environmental conditions in which we are all living, particularly those who live in poverty. So that's the big picture with respect to health. If we're talking about what we need to do in healthcare, it's that we need to prioritize the so-called cognitive disciplines in medicine to be reimbursed at rates that are equitable relative to the disciplines that are more technical and invasive in terms of the procedures that they do. So that I frame in the book the medical interview as the most important medical procedure we do as physicians, as potent as the surgical knife. And if we start to value that equally, we're going to begin to see changes the likes of which you're referring to.
I want to get right back to our guest. We're talking with Dr. Dean David Schillinger, director of the University of California, San Francisco Communications Research Program. His new book, Telltale Hearts, A Public Health Doctor, His Patients, and the Power of Story. He is still with us from San Francisco. Dr. Schillinger, I want to ask you why tell our audience it's important to understand what goes on in the nation's public hospitals. We talk a lot with doctors. A lot of them are more, I guess you would say, private institutions. Why is it important for us to understand what goes on, what you have seen at a public hospital?
Well, first of all, I'd say, our prior conversation was really focused on health policy and sort of policy wonk talk. But the book itself is full of really wildly entertaining and compelling stories, and I think really will grip the reader by learning about the kinds of experiences that patients in public hospitals have been exposed to that lead them to become ill. And public hospitals are really just the tip of the iceberg for the rest of the country's ills. It's really the only place where healthcare meets social reality, and they're hidden from public view for the most part. We think of public hospitals as the place where those people go to get their care, rather than the place where the kinds of health disparities that we observe also are relevant for many of the rest of us in the form of a health gradient. So this book is really not just about the bottom 10% of the United States, but really is about everyone except the top 1% in the United States in terms of how health happens and how healthcare quality can suffer when we overly rely on technology and not elicit the patient's story.
Well, speaking of patient's story, early in your career, you wrote about one of every two patients you admitted were dying of an AIDS-related illness. So early on, you were on the front lines of that. We actually interviewed Dr. Fauci a few weeks ago on his new book. He spent much of his career treating patients with AIDS. Like 70% of the book is about that early part of his career, although he's known for COVID. Talk a little bit about that experience and what it taught you about being on the front lines of this, at the time, sort of newish disease that was only affecting a portion of the population in San Francisco.
Yeah, I mean, these were very formative years. And in the book, it's quite clear that I was quite young and naive and unprepared, as were many of us, for the horrors of accompanying young people, young men, many of them our own age, to their death without the kinds of tools that we're used to having and that we were so fortunate to arrive at so quickly with the COVID epidemic. I mean, it took us a good 15 years with the HIV epidemic before we were in control of some effective medications. So for me, I think I learned how easily one can slip into a form of dehumanization when you don't really understand what the other person is going through, and how absolutely important it is to understand who the person is behind the patient and behind their symptoms. And for me, that was the ultimate lesson, which is my patients are not just a series of symptoms, but they are people who have families, who have histories, who have stories. And that once I understood that, I could approach their suffering or their recovery in much more humanistic ways and with much greater caring than if they were just a series of numbers. And I worry that today we often categorize people as having syndromes with certain numbers and certain technical characteristics, treating them as some people have called eye patients, as electronic patients almost, and that ultimately medicine is about one person connecting to another.
Well, Dr. Schillinger, that's what struck me. Your book, your patients have names. It's not just patient X, patient Y. It's Mrs. Johnson, it's Melanie, it's Mrs. Jimenez, it's Mr. Q, who you say was one of your most frustrating patients, yet one of your most treasured. You remind us that it's not just a patient and a file that a doctor picks up. It's a human being that has been living in certain conditions with certain ailments who has a specific story that is crucial to their health outcome.
Yeah, that's exactly right. And, the HIV epidemic was just one of many epidemics, and our patients are living through numerous contemporary epidemics, most of them non-communicable diseases like diabetes or exposure to secondhand smoke that leads to lung disease or cancer. It's not always the dramatic infectious disease that they have. And they get these diseases because they don't have the luxury that many of us do to eat the kinds of foods that we know are healthy, or breathe the kind of air that we know is healthy, or live in the kinds of neighborhoods that we know are healthy. Many of my patients are subject to very little choice in that regard. And in fact, I show in the book how many of the health outcomes that we see are a direct result of policies that the U.S. government and the U.S. banking system pursued as it relates to redlining, where people of color could purchase homes or not purchase homes, where they could get a mortgage or not get a mortgage. That 75 years later is still determining who lives and who dies in which neighborhoods in a city. And it's quite compelling to see that kind of through line still existing so long after the laws have changed. So it really makes the argument that if we're going to improve health, we have to take a step back, listen to patient stories, bring those stories together, and change public policy, not just health policy, but social policy.
All right, just have about 30 seconds left here. So we're all kind of listening and thinking, okay, wait, so what do I need to do as a patient to make sure I can improve my health? And forgive me, because we only have about 30, 40 seconds left.
I think as a patient, we need to be proactive in telling our stories to our physicians. We don't have to be so deferential if we get cut off. It's okay to gently state our case. And I think we need to value more the ways in which our communities are designed, the ways in which our food system is created, the ways in which transportation is done. All of these things are going to influence our health in much greater detail than what we eat for dinner tonight.
So appreciate the time with you. Dr. Dean David Schillinger, thank you so much. Director of the University of California, San Francisco Communications Research Program, author of his new book, Telltale Hearts, public health doctor, his patients, and the power of story. This is Bloomberg.